This is Dr. Greg Kirwan. He is a board certified fellowship trained physician who specializes in orthopedic foot and ankle surgery. Dr. Kirwan's area of expertise includes total ankle replacements, complex deformity reconstruction with novel 3D printed patient-specific implants, bunion corrections, fusion surgery, and sports injuries of the foot and ankle. Has served as a orthopedic foot and ankle consultant for several D1 university sports teams. Dr. Kirwan is new to the Jersey Shore, but he is from the Philadelphia area. He attended the United States Naval Academy for undergraduate studies, and he was a member of the Navy football team and the rowing team. He was in the Navy then for 5 years, earning 7 medals and commendations during his service. He completed medical school and his orthopedic residency at PCOM and followed up with his fellowship at the University of Pennsylvania. We are so delighted to have Dr. Kirwan here with us at Rothman Orthopedics, and nobody came to listen to me talk, so I will let you take it away. Thank you so much.
Thank you, Kristen, for that nice introduction. Good evening, everybody. I just want to say thank you, and we really appreciate you taking time out of your busy schedule to listen to the lecture today and to join us here. Like Kristen said, I've been practicing for about 13 years now and just joined Rothman within the past 2 months, and very excited to be here. Tonight, we are going to touch on the topic of arthritis in the foot and ankle. This is a very big topic, and why? Because unlike the hip and the knee, which has one kind of larger joint surface, in that structure, there's just a few bones, but the foot and ankle has so many bones and so many joints that it can be a challenging diagnosis and exciting thing to treat from a orthopedic surgeon perspective. So I have no financial disclosures for this. So basically tonight, we'll spend about 20 minutes or so. We're going to overview the anatomy briefly and go over what is arthritis, how does it happen, what does it usually feel like? What are some of the common complaints that patients will say to us where we can think, hey, that might be arthritis? How do we differentiate that from something else? And also what an office visit will be like, what is important in the evaluation of arthritis. And then, once you're diagnosed, what are the treatment options? So very quickly. So I do like patients to have a little bit of vocabulary and some of the terms down, because especially today with the electronic medical records, patients are allowed to look at their chart, and they may see some terms there that they may not understand. So in general, the ankle and foot is separated into 3 different regions, really. In the foot and ankle, there's 28 bones if you include the sesamoids, which are 2 little bones under the joint of the big toe. But when we're talking about hindfoot arthritis, the hindfoot is the area back by the ankle and the heel bone. It includes the ankle joint, the subtalar joint, which is this bone, the talus, which is the bottom bone in the ankle, sits on that heel bone, and then the talonavicular joint and calcaneocuboid joint, which are right in front of that ankle. In the midfoot, which you'll hear the term midfoot arthritis very commonly. It is the joint of the navicular cuneiforms, which are the bones of the midfoot, and a large bone called the cuboid. But the navicular cuneiform and what we refer to as the tarsal metatarsal joints. The metatarsals are these long bones in your foot, and each of those bones line up with a bone in the midfoot. If we go out towards the toes, we're going to talk about the forefoot, and that includes the toe joints and then all the little joints in the toes. The ball of the foot is your toe joint, so that would kind of be, if you could see my mouse, that would kind of be this area right here. So this would correspond to the ball of your foot when we're talking about structure. So what is arthritis? Basically, arthritis is damage to the cartilage of a joint. At the end of our bones, where a joint is located, we have something called articular cartilage. That is the tissue at the end of the bone. The 2 ends of a bone, or maybe even 3 bones, meet at the joint, and the cartilage surfaces oppose one another. On an X-ray, the cartilage appears as a space between the bones, but it's not really a space in our body. And with movement of those joints with normal cartilage, we can't feel that, which is very good if you think about it. You don't want to feel moving your joints all the time. So there's no nerve endings in articular cartilage. So once that cartilage is damaged, however, or is degenerative, and that leads to a cascade of events. So degenerative joint disease, which is also another name for arthritis, that movement of the damaged joint is what causes pain. Damage to the cartilage leads to what's called the subchondral bone. That bone is now exposed. And unfortunately, the subchondral bone has many nerve endings. And so when you move that joint, if you have cartilage that is missing, exposed subchondral bone that has the many nerve endings, when you move that joint, that is the pain generator from arthritis. And this can cause a wide array of symptoms. So with arthritis, how does the damage start, really? So when we're talking about arthritis, we're really talking about three big things. The regular old osteoarthritis, which is the most common. This is just the normal wear and tear of joints over time, father time catching up with everybody. That can be many factors. It could be the lifestyle that you lead, like the type of employment, if you're a heavy laborer versus someone who sits at a desk all day, your activity level, exercising, high impact activities, and whether or not if you were a high level athlete or very active when you were young. Another cause for arthritis is what we refer to as post-traumatic arthritis, and that would be after a fracture to a joint or multiple injuries in the ankle. We think about multiple ankle sprains that can cause some ankle instability. The ankle moves abnormally, and that can cause degenerative arthritis from damage of the cartilage. Also, another big umbrella for arthritis is the inflammatory arthritis, which would include rheumatoid arthritis, gout, which is fairly common, and psoriatic arthritis. That's a very big umbrella, but basically is referred to as inflammatory arthritis. Now, with the ankle itself, the ankle is very unique. We hear a lot about hip and knee arthritis. You see a lot of commercials about hip and knee replacements, but you don't really see too much in the media or out there in public about ankle arthritis, although it does occur. Almost 100% of the ankle arthritis is going to be either from post-traumatic arthritis or inflammatory arthritis. So someone with rheumatoid or someone who sustained a fracture, even if it was treated non-operatively, may lead to arthritis developing in the ankle. We do see some osteoarthritis develop in the ankle, but for the vast majority of patients, it's either going to be post-traumatic or inflammatory. So arthritis, what do we usually want to hear from patients if we're thinking arthritis, or what are the common complaints? So some of the symptoms that you'll see is obviously pain and achiness in the involved joint. Occasionally you'll get some sharp pains, and that can occur from maybe certain movements or certain activities that you do that may catch some abnormal joint surfaces there, cause a sharp pain. Sometimes you may have loose bodies, which are pieces of cartilage or bone that break off and are in the joint. Sometimes they can get caught. So, but generalized achiness with occasional sharp pain. Something called morning and startup pain is very common too. It's counterintuitive, but an arthritic joint does not like to sit still. So if you get up in the morning, if you have arthritis of your back or your knee or your ankle, a lot of times when you first get out of bed and try to walk, your joint will be very stiff. It will be painful. But after a few minutes, you notice, oh, that pain's not that bad. That's morning pain, and startup pain is kind of along the same line, but it's if you're sitting down for a while. So if you have a long dinner, or maybe you go to the movies or something, you get up and that joint again hurts you for a little bit of time. But if you're in a movie theater, by the time you get out to your car, the affected joint may not hurt you as much. You can also get activity-related pain towards the end of the day. Some joints, especially the ankle, you can feel some instability, like the ankle is going to give out or give way. You may also have some clicking or what we call mechanical symptoms, sort of like a grinding of the joint when you move it. And again, that could be from some loose body or abnormal joint surfaces. fluid on the joint, which is the swelling in the joint. An arthritic joint produces a lot more joint fluid than normal. And especially with, if you do too much activity and you exacerbate your arthritis, you can get that swelling of the joint, which we refer to as an effusion, but commonly known as fluid on the joint. Also, warmth in the joint can occur too. More common probably with like a gout type of scenario or something, but even with osteoarthritis or post-traumatic, you can have some warmth in the joint. So overall, and this is really in general, like when should you go see somebody with pain? I mean, basically, if you have several weeks to months of similar pain and symptoms, same area of the foot or ankle, happening every day, and if it's starting to affect your activities of daily living, like self-care and responsibilities, either like running errands or the routine care at home. Of course, if it's affecting your quality of life, social activities, exercising, and what you like to enjoy doing. If you like to go dancing, are you not dancing anymore? Do you like to go for walks or hike and you can't do that anymore because pain in your foot and ankle? Obviously, if it's interfering with your employment or your job duties as well. So also the over-the-counter medications. Two big medications are the non-steroidal anti-inflammatory medications. That would be your Aleve, your ibuprofen, Advil, stuff like that. Tylenol is another over-the-counter good pain medication, and that just blocks pain receptors in the body, and that is very good for arthritis as well. But if you're taking them and they don't seem to really be doing anything, that may be a sign that you want to get looked at as well. And also pain that is just continuing to worsen, become more constant, that is another reason. So what to expect during the visit to the orthopedic? Basically, with pain in the joint or anywhere in the body, your medical and surgical history is very important. In terms of the foot and ankle, definitely we would want to know if you have had any surgeries, from history of a fracture, or even any soft tissue reconstructions, like a ligament reconstruction for ankle instability. So that's very important. The quality and severity of your pain, again, when does it happen? Are you getting that pain when you get out of bed? Are you getting that pain after dinner when you try to stand up and walk? What you've done for prior treatments and medications. Have you had any injections in the joint? Have you taken the over-the-counter medications, and has that helped you, or does it alleviate some pain? What exacerbates your pain, or what alleviates your pain? Those are all important questions from the history, and kind of to get an accurate story for each individual patient so we can come up with a plan. Weight-bearing x-rays. I don't think there's anything more important and instrumental than weight-bearing x-rays for the involved joint. Pretty much the hip, knee, foot, and ankle, the lower extremity that are weight-bearing joints, you hopefully will be getting weight-bearing x-rays if you see someone for your joint pain. The shoulder and upper extremity are a little different because they're not weight-bearing x-rays, but these are instrumental. And sometimes patients may have had x-rays with their primary care physician or at an urgent care center, but they were not weight-bearing. And sometimes the patients are a little perturbed that they have to repeat their x-rays, but if you've had previous x-rays that were non-weight-bearing, vast majority of times you won't be double charged. That's a common issue that comes up, like patient worries, or am I going to get charged for these x-rays? I just had them. But weight-bearing x-rays are needed for a complete evaluation of the foot and ankle. And obviously, one of the most important things is physical exam as well. Once all these things are done, then we come up with a plan of action for you and tailor it to your specific joint and your specific problem, where you're at in the course of things with your arthritis. So with the weight-bearing x-rays, again, a benchmark of arthritis evaluation. So how do we get from the x-ray on the left of the screen to the x-ray on the right of the screen, which shows some pretty bad arthritis in the ankle and also the talonavicular joint? So what are we looking for basically on the x-ray, and why do we need it weight-bearing? The weight-bearing puts the force through the joints, and that mimics what's happening when you're placing weight, because one of the most common things is that an arthritic joint may hurt more when you weight bear or do stuff. So we want to simulate what that joint is looking like when you have your weight on it. So one of the most common things that we start to see is thinning of the joint space. So usually, again, that cartilage does not show up on x-ray. So it will look like a space on the x-ray, but it's not really a space in your body. And right here is the subtalar joint. And you can see a little space there, but in the body, that's not a space. That's the articular cartilage that is just not showing up on the x-ray. So you can see here, the ankle joint, talonavicular joint, really bad arthritis there. We also see bone spurs. These are referred to as osteophytes sometimes on an x-ray report. But you can see in the front of the ankle, you have bone spurs sticking from the joint. Also from the top of the subtalar joint. And these are just little projections of bone that usually form around the periphery of the joint. Sclerosis. This is another finding on the x-ray, which is an increased white signal in that subchondral bone. So you'll start to see this bright white line where the joint surface usually was, right underneath where that cartilage was. And also then bone cysts. And how this occurs is the joint fluid, once the cartilage is damaged, the joint fluid can get into the bone underneath the cartilage. And that will kind of, lack of a better word, kind of eat away at that bone and form some cysts. So these are usually fluid-filled cysts in the subchondral bone. And you can see these on x-rays with like dark oval or circular structures, kind of right underneath that sclerosis or that joint space. Also very, very important, especially in foot and ankle, to get the weight-bearing x-rays for deformities. So this is very important when we start talking about treatment, but ankle deformities and arthritis can really kind of dictate what we can do surgically. But the deformities may not always show up on a non-weight-bearing x-ray. So this is, again, crucial for the evaluation of arthritis. So after the physical exam, after the history, after the x-rays, when we review them, if you're diagnosed with arthritis, now what? A lot of people say, Doc, do I need surgery? Even though you may be seeing an orthopedic surgeon, there's still a wide a range of treatments available, even without surgery. So here at Rothman, we have orthopedic specialists and physicians that provide top-notch non-operative care. So it doesn't mean that you're always going to sign up for surgery when we see you initially for your arthritis. I always tell people, you know, we may look at an x-ray and you may have arthritis, but everyone's different. I may see a patient with their x-ray is, you know, the worst arthritis I've ever seen in their toe joint or their ankle joint, and they don't have a lot of pain. So we listen to your body, we listen to your joints, and I always tell patients, your joint will tell you when to do the surgery. I think it's a lot better to try all of the conservative care, because then it's easier to wave the white flag and have surgery. But a lot of different treatments are available. So in terms of arthritis of the foot and ankle with non-operative treatment, activity modification is important, shoe modification. So again, if you have arthritis of a joint and you like to do high impact activities, let's say if pickleball is the new thing, you know, and if you play pickleball every day and the ankle arthritis that you were diagnosed with seems to be getting worse, then, you know, we can maybe go down to a few times a day and cross-train, do some low-impact stuff. Weight loss is important. When you walk, it's 5 to 7 times your body weight across the foot and ankle. So if you lose a pound on your belly, it's taking about 5 to 7 pounds of force off of your foot and ankle when you walk. Other non-operative treatments, we touched on the anti-inflammatories. There's over-the-counter. There's also prescription ones. Orthotics of the foot and ankle, especially with flat foot or high arches or some deformity in the foot and ankle, that can be another option. One of the very unique things about arthritis of the foot and ankle is bracing. The arthritis is very amenable to bracing. And you see a few different options on the screen there. The one in the middle is called an Arizona brace. That's one of the most common ones. These braces are not going to really take care of the problem, but they're going to help control your symptoms. So if your pain is severe at the end of the day, 8 or 9 out of 10, maybe if we put you into a brace and you wore the brace during certain activities even, or throughout the day, maybe your pain is a 2 or 3 out of 10 at the end of the day. And that is, considered a win for non-operative treatment. The insert all the way on the right is called a Morton's rigid extension. That is used for the arthritis of the first toe joint, the big toe. And that is a very thin carbon fiber insert that restricts motion of the joint, and again, helping to alleviate some of that pain. Injections, cortisone is an option, Toradol, which is an anti-inflammatory, but not a steroid, and PRP, which is platelet-rich plasma, which is kind of like a new, kind of like a stem cell type of thing, where we take your blood, spin it down into something called PRP, and inject it into the joint. There's not a lot of data with foot and ankle arthritis with PRP injections, but they are used, in other joints and other soft tissue conditions as well, too. So non-operative treatment, we have a lot of options before we get to surgery. Surgery, though, with so many joints, so many bones, the surgical approach varies. And we have right here 5 options listed for surgical treatment of the foot and ankle. We have joint replacement, which we use in the ankle joint a lot, ankle replacement, and the great toe joint, or the first MTP joint, or the big toe joint. We do also a cheilectomy, which just means bone spur removal. That's also common in the great toe joint. Osteotomies, that's a fancy word for cuts in the bone. We sometimes do cuts in the bone to realign them, to maybe take some pressure off of the joint. So that's an option, usually in early arthritis. Fusion of the joint. For most joints in the foot and ankle, this is the gold standard. People don't like the word fusion. It just scares a lot of people, but they are usually very great surgeries and a good option for pain relief. There is also more minimally invasive options in foot and ankle surgery that we're using, and that, that just helps with kind of less pain, less swelling, and an easier recovery from normal traditional, what we call open procedures, where a big incision is made. And then interpositional arthroplasty, which again is common in the great toe joint. That's just a fancy word for, we put something in the joint, whether it's local soft tissue like a tendon slip or a joint capsule, or synthetic things like a graft material that will again reduce some symptoms. So surgical treatment of the ankle and the hind foot. Ankle, we have fusion and replacement options. For all the other joints in the hind foot, we basically have a fusion. And a couple pictures here on the top. In the middle is a typical ankle replacement. There's a lot of different companies, a lot of different implants, and they've gone through a lot of changes over the past couple decades. But on the upper right, this is the typical ankle replacement. In the bottom on the central aspect, that's what a type of configuration for an ankle fusion. Basically, an ankle fusion is hardware across the joint that will compress bones together, and basically it removes the joint. So the differences between a fusion and a replacement: the fusion will get rid of motion. A lot of times we don't have a lot of motion in these joints anyway, but any remaining motion that you have, it will sacrifice that motion. Because in a fusion, what we do is go into the joint, either open procedure or arthroscopically with the camera, smaller incisions. We remove the remainder of the cartilage. We prepare the bone surfaces. And basically what that does is kind of makes the bone act as fractures. And we put hardware in there that will compress the two bone surfaces together. And it kind of acts as like it kind of heals like a fracture would, where those bones grow back together. You don't have a joint anymore. So no pain. So it's a very good pain relief. But again, the big knock on fusion is that you will lose any motion there that you have remaining of that joint. With a fusion, there's risk of a non-union, which is when the two bones don't grow together. Because again, we're almost kind of tricking the body to grow these two bones together when there used to be a joint there. So that could be a risk of fusion and hardware loosening as well. With the replacement, an ankle replacement maintains your motion. Unfortunately, we don't get a ton of motion back. So basically what you have going into the ankle replacement surgery, you'll have that motion plus about another 10 to 20 degrees, depending on the outcome of the surgery. So you keep the motion that you had, gain a little bit, but not too much after the surgery. This is also good pain relief surgery. Sometimes you can get some incomplete pain relief where you can still have a little discomfort because it doesn't replace the entire joint surfaces. And there's some certain areas that can bother people, basically in the back on the inside of the ankle, where we can have something called posterior impingement occur. So another big difference between the refusion and the replacement is the fusion stresses the other joints because, again, you lose that motion, and other joints around the fusion can try to then compensate for the loss of motion of that joint, start to move abnormally, and there is actually a risk of getting arthritis in the joints around a fusion. It usually can take 2 to 3 decades, but it can happen, and we see it in really young people who have to undergo a fusion for a very bad fracture or something else like that. So with the replacement, with risks with that, it's like a joint replacement, just like the hip and knee replacements. They have the risk of wearing out and loosening and the potential for a revision surgery. So with the total ankle replacement, I'll touch on this for a little bit because this is kind of like a very hot topic now, right? Total ankle replacements have really come a long way in the past 20, 25 years. So basically, just like another joint replacement in the hip and knee, there are 2 metal components separated by a piece of plastic called a polyethylene. The remaining cartilage from the joint is removed, and then these implants are put in, and then the piece of plastic sits in between the metal parts and lets you keep moving that joint. One of the really interesting things in foot and ankle surgery, and also other joints too, but patient-specific instrumentation, where you can see these 2 white guides in the middle of the slide there. Those are made up specifically for the patient. It fits perfectly on the patient's anatomy, has really helped with bone cuts during the surgery and really to reduce that time in the operating room. So one of the other big things about total ankle replacement is that you need to be non-weight bearing after the surgery. The metal components in this joint have to kind of grow into the bone. So hip and knee replacements, you're up walking around, you may even do physical therapy that day. This usually requires several weeks of non-weight bearing. And also with an ankle replacement, there's activity level restrictions as well. Excuse me. After an ankle replacement, you can't run, you can't jump, and we actually use doubles tennis or pickleball as sort of the most intense activity that you can do after an ankle replacement. So that also limits some of the patients that we can put an ankle replacement in as well. Not everyone is a candidate. Some patient factors too that come into play, medical conditions, diabetes, especially patients with neuropathy, patients with peripheral vascular disease, severe deformities that we can't correct and then put an ankle replacement in either in the same surgery or stage surgeries. Those are some patients that may be better off with an ankle fusion. But again, a lot of factors go into it. This office visit with ankle arthritis between ankle replacement and ankle fusion is the most detailed office visit that I will have, certainly by far. It's a long discussion. We got to figure out the best thing to do for you. So previous surgery also. Did you have an infection in the ankle? That's important. Usually that's a contraindication for ankle replacement. And also your age, activity level, and employment because of those restrictions after the ankle replacement. So this is just a little bit more on that patient-specific implantation. So the picture on the upper right is actually made after a CAT scan, a special CAT scan of your ankle. And those pieces that represent the bones are an exact match to your anatomy. And then the cut guides are made to exactly match your bone surfaces. So in the lower picture, you can see those guides that are now on the patient's foot and ankle, and that kind of guides our cuts. It has significantly reduced the OR time. And this, the picture of all this stuff on there, the page there is kind of what we see as surgeons as the pre-op planning. This can take a couple months to actually plan for this total ankle replacement. So patients do have to be patient when we're really, looking into an ankle replacement. So It has high patient satisfaction though. It has about 90% satisfaction rates after ankle replacement. Implant survival, which is implants that are still in a patient at about 10 years, or about 80 to 90%. So it's a very good option in the right patient. We continue to get better with these implants, and I think it's only going to be a better option going forward. So we actually can even combine this with some entire bone replacements. In this lower picture, actually, we have an entire talus bone, which is the bottom bone in the ankle, replaced by a complete metal bone. There's also more options coming out that are non-metal, that are a special type of plastic that we can implant as well. So moving on from the ankle into the midfoot, we got the midfoot and forefoot, and then we'll be done. But again, pretty simple, straightforward for the midfoot. Fusion of the midfoot joints is the primary option. Motion is sacrificed for your pain relief, but the good thing about this is there's minimal motion in these joints across the midfoot that we usually fuse. They really just act as rigid lever arms to propel yourself forward. So the lateral part of the foot, which is on the outside by the fourth and fifth toe, that cannot be fused. Those joints have to be left supple to accommodate uneven ground. So a lot of times patients won't have symptoms there, even if they have arthritis on the x-ray. But if they do, interpositional arthroplasty is an option for that. Forefoot arthritis. So now we're out by the toes. The vast majority of arthritis in the forefoot involves the big toe, the great toe, first toe joint. A lot of different ways to refer to it, but it's the first metatarsal phalangeal joint. This is also known as hallux rigidus or hallux limited. The smaller toes can develop arthritis, but again, we don't see it too often, or we see it and patients don't have pain. But a lot of surgical options, again, just like in the foot and ankle for the first toe joint and also the smaller toes. So you can see in this x-ray, this patient has arthritis of both the first MTP joint, the first toe joint, but also in the other joint in the big toe. And you can compare that to the other joints at the toe joints and how they're nice and smooth and uniform black space there. So chilectomy is when we remove bone spurs. Again, one of the first things we can see are these bone spurs form, and we can still have good joint space on the x-ray. This is a great option where we clean out the joint, we take the bone spurs off, and this actually may help the joint go back to a normal range of motion and maybe slow the progression of the disease. This is usually done in earlier stages, and the goal is to retain and improve the motion and obviously relieve some pain. So osteotomies are cutting bones to improve alignment. Interpositional arthroplasty, again, stuffing the joint, very common in the first toe joint. This picture kind of shows this graft material that is draped over what's called the first metatarsal head. This again relieves some pressure and maybe some pain symptoms in the joint. But these surgeries, other than the fusion, are kind of a stepping stone to that final surgery, which is a fusion of the first toe joint. Joint arthroplasty or joint replacement in the first toe is kind of controversial. A few decades ago, silicone implants were put in, but that found to have a high incidence of what's called synovitis, which is very high inflammation in the joint. But there's other options as well. But usually these are reserved for low demand individuals. In active individuals, we have to remove some bone. And then when we put these implants in, if they loosen, the only option is to do a fusion. And it can lead to some bone loss, and which makes a very complex fusion surgery for the first toe. The first toe is either shortened or we need to use grafts, which is a complex surgery to make up for that motion. So these are just some of the examples of those first toe implants, the joint replacement. So fusion is still the gold standard. First patient, or the first thing patients will say is, how can I walk like that? But the function is very good. Usually if you have really bad arthritis of the first toe joint, you don't have a lot of motion in that joint anyway. So it's a very good pain relief surgery, and you can be very, very active with fusion of the first MTP joint. The position that we fuse it in, and also the other joint in the toe, starts to compensate, and you can be very active. You can walk, you can hike. High heels are difficult, usually about an inch and a half heel is about what the max that we could tolerate if you want to wear high heels. But very, very good option. And this is either done with screws, staples, or plates and screws, as you see here. So the forefoot, the other smaller toes, although we can see arthritis there, again, we're unable to fuse any of the metatarsal flanger joints, the toe joints. So our options are kylectomy, again, osteotomies, resection arthroplasty, or resurfacing implants in these joints. The smaller joints in the toe are sometimes even fused for just like a hammer toe correction as well. Those can be fused, and patients usually still function pretty well, even with a stiff toe. So the summary from today can be a challenging problem, but also, especially with surgical treatment, patients can be very happy once this pain from the arthritis is relieved with non-operative or surgical treatment. So, we get good pain relief options with both non-operative and surgical intervention. The total ankle replacements have definitely come a long way, and they will only continue to be a really good option. The designs are improving, the patient-specific implantation. So we're very, very excited for total ankle replacements in the future to continue to provide a good option. Fusion surgery, although patients don't like the word, it can provide good pain relief and surprisingly good function. So thank you very much, and open it up to questions now.
Thank you so much. That was super interesting. I feel like I learned a lot.
Oh, good. Thank you.
All right, let's see if we have any questions pop up. Maybe you explained everything really well.
With no questions at the end, it's either really good or really bad. But we'll see.
I think personally, I think it was really good. I find this really interesting. Okay, here we have one. Can you get cramps with arthritis?
Yes, you can. I don't want to say no, you can't, but yes, you can. I mean, some of the cramps are usually muscle spasms in the foot and ankle. Sometimes that can occur from an injury to the muscle itself, the tendon, and then as a reaction to that, the muscle can cramp. But what an arthritic joint does also is causes a lot of local inflammation, and especially the small muscles in the foot, they can react to that inflammation that is locally found there and cause cramping. So yes, it can be one of the symptoms that we see.
Okay, next, if ice helps with temporary relief, does that indicate what may be wrong?
Ice is usually a very good option for the anti-inflammatory effect. The coldness of the ice reduces inflammation. Usually that is good after an activity, if you have pain from an activity, or if you have swelling of the joint, or definitely after an acute injury, like an ankle sprain, like a fracture, to get that swelling down. But it can help with arthritis for the swelling. If the next question is usually what, heat or ice? If you're going to do an activity and you have known arthritis, before the activity is when heat may be most beneficial to get the joint loosened up a little bit, allow you to do that physical activity.
The next question I have is, how effective are the cortisone shots, and how long can relief last, and how often can it be used? It's a good question.
That's a great question. And not to dodge the question, but it's very variable. In general, the cortisone injections they're temporary. They do help a lot with symptoms like pain, like swelling of arthritis. If you are initially getting injections, you may have a very good response to the cortisone injections. Sometimes I see people that get an injection in their ankle, I see them a year later. Sometimes there's patients that are like clockwork, and you can get a cortisone injection about every 3 to 4 months. We like you to wait as long as possible, but some patients need that injection. Maybe they can have surgery, or they don't want to have surgery at this particular time. So we do like to wait at least 3 months for a repeat cortisone injection. And I have some patients that 3 months and 1 day, they are back in the office for their next injection. Usually what happens is the cortisone injections will stop working, whether or not it just can't relieve the pain from the arthritis because your arthritis has advanced so much, or they're just losing their effect on the joint. But it's very variable, but it's always an option. If you get one and you don't get too much relief, sometimes we talk about maybe doing it again. But definitely after 2 injections, I would say that they may not help you.
Are hammer toes arthritis? Or I guess another question is, what are hammer toes?
So hammer toes are a deformity of usually the lesser toes, of the smaller toes. You can get it in the big toe. But those are usually contractures around the 2 joints in the toe. You can certainly have a hammer toe deformity that what we refer to as a rigid deformity, which is where we can't really straighten the toe passively if we take the toe and try to straighten it on exam, where it just won't straighten. That can be seen without arthritic changes in one of the joints in the toe. But yes, you can get arthritis in a hammer toe. You could have a hammer toe without arthritis, though.
Can you run and hike after fusion for hallux rigidus?
Yes, so you can be very, very active after a fusion of the first metatarsal phalangeal joint. One patient that comes into mind is a 50-year-old gentleman that still liked to play in a pickup men's soccer league. He continued to play. So certainly walking and hiking are absolutely 2 activities that you can do. Running, I would say that that's more variable. If you are a long distance runner and you like to run 30, 40 miles a week, you may not get back to that. You may be able to run, but maybe less mileage. And we might have to talk about cross training. Maybe you can still go out and run, but 2 or 3 times a week. Maybe do some elliptical or walking or other aerobic activity. But long distance running and a lot of mileage is difficult after first MTP joint fusion, but you could still be very active.
Great. Like to hear that. Can you fix a broken toe?
Yes, we can. Usually it depends on the characteristics of the fracture. One of the things we talk about is displacement. So if the bone has fractured and it has moved a lot, if the fracture is causing a change in the alignment of the toe, this is pretty common for like 5th toe fractures, the little pinky toe. You get it caught on the bed frame or furniture, and it's sticking out like that because of the fracture. Sometimes we can try to push that back and get it realigned. So that's kind of what we're looking at. How does the toe look clinically? Like when I look at it on an exam, is it crooked? Do you feel like it has changed position with the fracture? So it really depends on the displacement, whether or not the fracture enters one of the joints. But vast majority of times, they don't require surgery, especially the smaller toes. The first toe is a little bit more important, takes a little bit more stress, very important for pushing off an activity. So it might be a little bit more aggressive for fractures like that in the first toe. But yes, you can absolutely may require surgery for a fractured toe.
Any exercises you recommend for sore, achy ankles due to arthritis?
Yeah, so one of the most beneficial things is maintaining activity for that joint. Again, the arthritic joint doesn't like to sit still, which is kind of counterintuitive, but it also doesn't like that very high impact activity very frequently. So the best thing for foot and ankle arthritis is a good either formal physical therapy program or a home exercise program that we may add into the non-operative treatment. What that does is really strengthens all of the muscles in the foot and ankle. Maybe will help with any imbalances or deformities in the foot and ankle, and hopefully a good, strong foot and ankle will lessen the burden of the arthritic joint. But in terms of like physical activity and what I suggest, the low impact walking, biking, elliptical, swimming are really, really good for the foot and ankle with arthritis.
Great. Are vitamins and supplements and arthritis creams effective?
Yeah, so all of the supplements, vitamins, you'll always hear on a commercial or on the bottle that it's not FDA approved, not approved to treat certain disease or something like that, certain condition. However, I will tell no one to not try it because, I don't know how you're feeling. And look, we try to hold off on surgery as long as possible because a lot of these surgeries are the same next week or next month or next year, right? So anything that is available, either over the counter or, supplements, we do usually recommend calcium and vitamin D for sure, vitamin C for collagen production in the body, which is important for bones and soft tissues. So a multivitamin, especially vitamin C, calcium, vitamin D, but we definitely recommend those. But the other stuff like chondroitin, I think with that, go ahead and try it. For some people, whether or not it's a little bit of a placebo effect, it's okay if it makes you feel better and it's safe to use and it's from a reputable company or something, then we absolutely try those for sure.
Can the foot grow nodules due to rheumatoid arthritis?
Absolutely. They are called rheumatoid nodules. They are fibrous masses that can grow on the foot pretty much anywhere. Usually, if they stay small and are off the weight-bearing surface of the foot, we can watch them. A lot of times they end up interfering with shoe wear, or if they're on the bottom of the foot, the plantar aspect of the foot, we can remove them. Sometimes they may come back, but some of them can actually get up to about the size of a golf ball, and that can really cause patients some pain, especially if they're on the bottom of the foot or around some of the toes. But yes, they can be surgically removed.
What do you recommend for valgus deformity patients? I could have mispronounced that.
Yeah, so valgus deformity is a particular deformity of the foot and ankle where the heel bone kind of kicks to the outside. It's very common with flat foot deformity. Usually, first-line treatment is, again, a good physical therapy program. The arch of the foot is controlled by a specific tendon called the posterior tibial tendon in the ankle. We try to strengthen that if it's still working, if it's still functioning, and all the other foot and ankle tendons for that matter. Usually the first line treatment is maybe an orthotic, either over the counter or custom orthotic. That's when, if orthotics fail, that's when we also go to those braces. A lot of times with a valgus deformity or a bad flat foot deformity, the fulcrum's up a little higher in the ankle, so you need something to come above the ankle joint. And if it's what we call flexible deformity, maybe get that foot and ankle in a better position. If it's a rigid deformity, which is associated with arthritic changes, sometimes we just brace the foot and ankle where it is, and that can still help with symptoms though. So orthotics are big, physical therapy are big, especially early, and then bracing. Injections, not really for that unless there are arthritic joints which really bother you, and then there are surgical procedures as well.
There is a question further down here about how the effectiveness of custom orthotics.
Yeah, that's a great question. And it's sometimes controversial because custom orthotics, very few insurance companies cover those. And a lot of times you have to end up paying out of pocket for that. The reason for that is that insurance companies do not like covering things that aren't or have not been shown with good studies to be more effective than another treatment, right? So the custom orthotics, you may end up paying for them because there's not really a lot of very good high level quality studies that have shown custom molded orthotics do anything better than an over-the-counter. So that's a conversation in terms of arthritis, patient wishes and specifics. Sometimes we try an over-the-counter orthotic initially, a good one that will be maybe $50, $60, and then maybe move on to the custom orthotic. It's certainly worth it to some people to pay a little bit out of pocket to try to avoid surgery, and I'm all for that as well. Flat foot deformity is one of the most common things. That's the valgus deformity. High arches going the other way with a very high arch. Those are some of the instances where we'll try an over-the-counter and then go to custom orthotics and then see what happens.
And just as we're talking about custom orthotics, I have a question about custom braces. Can you get one while you're waiting for an ankle replacement?
Yes, you can. That's a great option before surgery. Again, going back to insurance, Medicare right now covers one of those custom molded braces, like an Arizona brace, usually every 5 years. Sometimes it's 2 years, depends on if you have some supplement insurance, but custom molded bracing, whether it's a stiff brace that's going to kind of lock you in and not move too much, or a brace that kind of gives you some motion still, those are absolutely great options in the non-operative realm of treating ankle arthritis. And they are sometimes the only option if patients can't have surgery, like uncontrolled diabetes or too high risk because of other health problems. Great option for ankle and even hindfoot arthritis.
And then we have a couple of questions regarding shoes. Someone's asking about well-fitting Birkenstocks. Do they help? And then do you recommend a stiff-bottomed or flexible type shoe?
Sure. Shoe questions always come up, and I feel a little bad about giving you my answer. It's hit or miss. There has not been one brand of shoe that has shown to provide people relief from all foot and ankle conditions. But some general things, like the rocker bottom shoes, a lot of times that helps when you have arthritis in the foot and ankle, like the big toe, because that kind of curved rocker bottom lets you kind of walk and kind of go forward, just like the bottom of a rocking chair, with minimal stress and motion and pressure on the joints. So something like that may help people. But in terms of a specific brand, there really hasn't been shown anything, one brand or another. For example, for 40 years, we're working out and exercising. Around the age of 40, I started wearing Brooks Ghost sneakers, and I will wear them for the rest of my life to exercise.
I'm writing that down.
And it took me till 40 to figure that out. So other things, that will help are a stiffer soled shoe, especially for that first toe arthritis. So you may feel better in a stiff soled shoe rather than a flip flop or bare feet. And that goes along with that Morton's rigid extension, that thin carbon fiber insert. What's the pain from arthritis, right? Painful motion, motion of a damaged joint, right? And that causes you pain. So if a stiff pair of shoes, like a stiff sole shoe, is going to limit the motion, then, sometimes people feel relief if somebody has to wear a steel-toed boot or very thick-soled, boots in construction. They actually may feel pretty good if they have first toe arthritis and they're at their job. They come home in the summer, they put some flip-flops on, or they're walking around in bare feet and they have pain. It's kind of the structure of the shoe. Stiffer shoe, rocker bottom shoes may help a little bit with that arthritis.
Great. If someone has inflammation in both feet in the morning without pain, is this also considered arthritis, or is there an alternative diagnosis?
That could be some type of inflammatory problem. If x-rays have shown that the joint surfaces are normal, if you have that swelling and in that area, we take an x-ray and you have arthritis, you may be one of the people that has arthritis that looks worse on their x-ray. You're getting some swelling, but not a lot of pain. So if the feet are maybe just swollen and painless in the morning and no other symptoms, and that kind of resolves, that could also be some vascular issues, like the veins in your legs being a little bit leaky, what's called venous insufficiency. But to correlate that inflammation in the foot to arthritis, I would just recommend getting an x-ray for sure, a weight-bearing x-ray, to evaluate the joint surfaces.
Okay, and you mentioned veins, and I'm just scrolling
Mhm.
because I saw a question about varicose veins. Oh, do varicose veins sometimes mask arthritis pain?
They sometimes don't, they can be together. Venous insufficiency, where your veins have one-way valves in them, and the veins rely on the pressure all the way from the heart and through the arteries to get that blood back out of your feet, out of your ankles, through your legs. If those valves are leaky, you can get some fluid buildup in the leg. So usually venous insufficiency is global swelling of the leg, commonly below the knee. Sometimes it can go above the knee. But if you have swelling, especially if it's maybe something that isn't too bad in the morning when you first get out of bed, but throughout the day, your leg blows up, that's sort of maybe along the line of a vascular issue, venous insufficiency. Venous insufficiency, though, can cause a lot of pressure pain. It just causes a lot of patients discomfort all over their foot, all over their leg, and it's from something called increased hydrostatic pressure. You have fluid that is leaking out into your soft tissues, and it's like blowing up a big balloon, and that's going to cause you pressure. So obviously, that can be in addition to ankle arthritis pain, right? Because if most of it's in your calf, sometimes you can get swelling on the top of your foot. But again, it always goes back to the x-ray. If you have an x-ray that shows midfoot arthritis and you have a big puffy top of your foot from venous insufficiency, if you have ankle arthritis, your calf is blown up from venous insufficiency, certainly they can be additive, and the venous insufficiency does not help in that situation because it's just kind of like a double whammy. You're getting the pain from the pressure and you're getting the pain from the arthritis.
Okay. What type of splint can be used to straighten a big toe due to swelling in the joint?
Usually the easiest thing to do is an ACE wrap, like a 2-inch ACE wrap that's very thin. And you kind of wrap it around the foot and out towards the big toe. If you're getting swelling and inflammation from arthritis, usually some compression feels really good. You can also maybe find some neoprene sleeves that go on the big toe. A lot of times you'll see these as like a bunion sleeve or something, or a bunion compression wrap. But anything that causes kind of compression around an area that's swollen, again, either through the ACE wrap or a neoprene sleeve, will help with those symptoms.
What other pain relief is available for someone taking Eliquis?
Okay, good question. Eliquis is a blood thinner. And when you are on a blood thinner like that, you cannot take non-steroidal anti-inflammatories. And those are your Advil, Aleve, ibuprofen, Motrin, all that group, and also the prescription ones. It's a tough thing because the non-steroidal anti-inflammatories are the first-line treatment for arthritis, for non-operative treatment. So Tylenol is another option. That may be a point where we maybe go to a injection a little earlier than maybe we would in another patient. And also, especially for maybe like an acute exacerbation of arthritis, if you're kind of going through life, you have known arthritis, you do something and the pain goes through the roof, we can try prednisone or like a Medrol dose pack, which is a cortisone for a short period. You can take prednisone with blood thinners, but unfortunately, a lot of times you are really limited to Tylenol for over the counter.
Okay. few more questions. After a fusion, can there be nerve damage, and is there anything that can be done?
Absolutely. Anytime that we go into the foot and ankle surgically, there is risk of nerve damage. In the foot and ankle surgery, something called complex regional pain syndrome can also occur, and that's either after an injury or surgery in the foot and ankle. And it happens a lot in distal extremities, so the hands too. The hands and the foot and ankle are notoriously painful after surgery. We get a little bit better, we are a lot better actually with blocks to the nerves at the time of surgery. But unfortunately, nerve pain can be a very real thing after foot and ankle surgery. I mean, take first MTP fusions or ankle fusions. I pretty much do the same surgery to every patient generally, right? There's a little bit of uniqueness to every patient, but the surgical procedure and the technique is pretty much the same. And everyone's different with pain after the surgery, but the nerve pain can be a significant thing to deal with after foot and ankle surgery. But for that matter, anytime you cut into the skin, distally in the hand and the foot and ankle, you're inevitably going to cut some nerve branches, because a good way to think about it is if you have surgery up by your hip, you have a very big sciatic nerve there. And I'd say if you're having hip surgery, for the surgeon to avoid the nerve, it's like trying to avoid a tree trunk, right? A huge tree, right? You can go around the tree pretty easily. But in foot and ankle surgery, we're operating up where the little twigs and the leaves are. Very, very hard to avoid everything at a distal extremity. So nerves can be damaged even during surgery, where we go ahead and put retractors in and stretch them. The good thing is that nerve pain will usually recover. We can do specialized physical therapy if we're thinking that someone may have complex regional pain syndrome. I give nerve medication to every patient who has surgery. That really helps to avoid narcotics as well, with the blocks, with the nerve pain, with the nerve medication. So that's a big thing that we have found and adjusted the pain medications for foot and ankle surgery. In terms of what can be done about it, again, therapy, medications. Sometimes we refer patients to pain management doctors, which, sometimes people balk at that and say, well, I don't want narcotics for forever. Narcotics are not used for nerve pain, so that's really not used too often. But sometimes we get you to pain management doctors. Very rarely is there any surgery that can help with nerve pain after surgery. And also, actually, someone who does have complex regional pain syndrome are at risk of getting worse with further surgeries, or even down the line, years later, that can get kicked back up and become active again after another foot surgery. So it is a tough problem to deal with foot and ankle surgery and nerve problems.
Just as we're talking about pain meds, there's a question, what about Voltaren for arthritic pain?
Voltaren is one of the prescription non-steroidal anti-inflammatories in pill form. The gel, Voltaren gel, used to be prescription, but it's been over the counter now for several years, maybe even 4 or 5 years or so. But that is a very good option for foot and ankle arthritis, because those joints, especially on the top of the foot where we see midfoot arthritis, even the big toe, the ankle joint's a little bit deeper. It may not help with that, but we always do try it. But Voltaren gel is a very good option for foot and ankle arthritis. So we definitely recommend that in the whole realm of non-steroidal anti-inflammatories.
Great. And I know we talked about this with rheumatoid arthritis, but this seems like it's for general arthritis. Can arthritis in the fifth metatarsal bone give a feeling of a lump or stone when walking?
Certainly, if there's enough joint swelling, you can feel kind of like a prominence there around the toe joint. Another common thing that can happen in the fifth toe joint is what's called a Taylor's bunion or a bunionette deformity. And there also can be some bone spurs that form around the fifth toe joint. So again, arthritis in the lesser toe joints, pretty rare, but it can happen. again, going back to the X-ray, X-ray is the most important thing. The X-ray shows any bone spurs or bone protrusions. They can sometimes be taken out surgically through a very small incision or minimally invasively. So again, I go back to the X-ray on that one, but that's the most important thing to kind of evaluate the bony structure.
And I have two kind of related questions. Someone said had their big toe fused when they were 18. Can they still do a replacement after a fusion? And then someone's asking if you can get a fusion after an arthroplasty.
Yes, so if you had a fusion of the first toe joint, an arthroplasty is not an option. We have very limited experience kind of reversing what the normal course is. You can have a fusion after an arthroplasty, even in the ankle. It has not been done often, probably less than a handful of times to reverse an ankle fusion to an ankle replacement. In the big toe, I do not know of any cases that have gone from a fusion to a replacement, because one of the things that happens, again, with expectations after that surgery, if your toe has not moved since age 18, and I don't know if we know the age of the person that asked the question, but all those soft tissues have not moved in however long it has been. Let's say it's 20 years. Let's say you're 38. And you go in there, remove the hardware, make a fake joint surface, right? Because there's no joint there anymore. The bones grew together. And maybe you put a graft in there, an interpositional arthroplasty. Your toe's not going to move that well anyway, and it's probably going to cause you more problems and pain again than just keeping the fusion of the first toe joint.
Great.
And then also, I think
sorry.
the other part of that question was can you have a fusion after an arthroplasty?
After
Absolutely.
the arthroplasty.
Again, if these implants loosen, they sometimes can be prominent on the bottom of the foot. They can come out of the bone, but the surgery is to remove the implant and then fuse the first MTP joint. Sometimes it can get a little bit more complicated than a native fusion because of bone loss. And again, the two options are to accept shortening of that first toe, which aesthetically and cosmetically patients don't like all the time. Some patients don't mind it, and that's what we do. The other option is to try a graft material, whether that's metal or what we call an allograft, which is like cadaver or something, or like this new material that's sort of like a poly or a plastic type of device to make up that bone loss that keeps the toe out to normal length. But that's a very complicated surgery, and it's a case-by-case basis. We usually do get a special CAT scan, just like the one that we get for patient-specific implant instrumentation in the ankle replacement, to see what our options are to reconstruct the first toe joint after a failed arthroplasty.
Great. I have hammer toes and crossover toes that are making footwear difficult. Very recently, I have been getting a buzzing sensation in the sole of my foot. What can be done without invasive surgery?
Okay. I'll go backwards and I'll just say surgery is the only thing that can permanently correct the deformity, but doesn't mean that we always have to have surgery. There are some taping techniques of the toes where you apply tape over the top of the toe and under the bottom of the foot that can hold the toe in position. There's something called a hammer toe crescent pad, which is sort of like a crescent moon that has a little loop that goes around the toe, and you can kind of tighten that and it pulls the toe down. So there are some tricks of the trade that we can kind of realign that second toe. But what I was saying earlier about surgery, if you take the tape off, if you take the hammer toe crescent pad off, the toe is going to go right back to where it was. So there are options to not have surgery and control the position of the toe, but they're only effective when you're actually using those products or techniques. In terms of the buzzing or kind of like maybe a burning pain in the bottom of the foot, one of the most common things, the blanket term of pain in the ball of the foot is called metatarsalgia. Again, it takes its name from the metatarsals, which are the long bones in the foot. There's a lot of things that can cause metatarsalgia, but one of the most common things that we see people for are neuromas, which are a swelling of the nerve in between the second and third and the third and fourth toes. And sometimes people come in and describe a feeling of walking on a pebble or a stone. They may have some radiating pain out to the toes or actually back towards the heel. It's that feeling of walking on a pebble is just the actual neuroma that's kind of getting squished in between the bones there. So neuromas can get injections. We can try some shoe modification, some orthotics. Usually the injections are done under ultrasound guidance to get it right at the nerve. That's what I like to do. But a lot of times that's effective. You can have surgery if it's a neuroma too, where we cut the nerve out, the neuroma out, but you are trading numbness for the pain. We're cutting a nerve out, so you'll be numb in that area where that nerve innervates the skin.
This is a good one. What are the best treatment options for a completely flat foot? And this is someone who has arthritis throughout their body.
Okay. Two big general kind of compartments with surgery for flat foot. If that's we'll work backwards. If you have a lot of arthritis in your flat foot, that may lead to what's called a rigid deformity, where if you're sitting on the exam table and I take your foot, I can't make your foot look like it has an arch. And that's because the arthritis that has developed in those joints make it rigid. So I can't correct it. Totally different than a flexible deformity, where if you're flat-footed on X-ray, you don't have a lot of arthritis, and I can take your foot and recreate a normal arch while you sit on the exam table while you're not weight-bearing. That's a whole different surgical procedure, because something called a triple arthrodesis, or a fusion of three joints in the foot, is what's done for a rigid deformity. If it's a flexible deformity, in general, we do a tendon transfer, which is we take the tendon that goes out to your smaller toes, and we cut that tendon. We sew the stump to the tendon that goes out to your big toe so you can still move your smaller toes. We take that tendon, reroute it into the tendon that's responsible for the arch of the foot, the posterior tibial tendon. With that procedure, because that tendon transfer isn't as strong as the native tendon, we have to do a procedure where we cut your heel bone and shift it inward to give that tendon a mechanical advantage. It also helps correct the deformity. And then also, sometimes we have to do a procedure called a lateral column lengthening, where we kind of swing the foot over to kind of reconstruct the arch. So that's more of like a arch reconstruction, where we keep motion in the foot, or a triple arthrodesis, where you have a fusion of three joints. Other options, again, great option is the bracing that we talked about, orthotics too. So
Great. Side effects from injections. I don't know if we touched on that, but what does the recovery time from a hind ankle subtalar joint fusion surgery look like?
okay, so a subtalar joint fusion would just be where we fuse the subtalar joint, which is the joint below the ankle, where that talus bone sits on the heel bone, or the calcaneus. For that surgery, and most of the fusions of the hindfoot and midfoot, there's a period of non-weight bearing. For a subtalar joint fusion, I keep my patients 6 weeks non-weight bearing. We take an X-ray at that time. If the fusion looks pretty good, if you're feeling pretty good, we let you start putting a little bit of weight on in the boot, in a cam boot type of thing, a removable boot, and progress to weight bearing, full weight bearing in the boot, which is called weight bearing as tolerated, as soon as you can, or at about 8 weeks. But then you're in a boot for about 10 to 12 weeks after the surgery. So with most fusions, ankle fusion, hindfoot fusions like a subtalar joint, mostly 6 weeks non-weight bearing. For some midfoot fusions, we can do about 4 weeks non-weight bearing. Actually, a fusion of the first MTP joint, you're allowed to walk after surgery, right after surgery.
And how long is the recovery from a bunionectomy, and how long will they be non-weight bearing? And is there a boot?
So for most bunion realignment surgeries, you are allowed to walk right after surgery. There is a specific procedure called a lapidus procedure, which is where we fuse the first joint in the midfoot to correct the bunion. That usually requires a period of non-weight bearing, anywhere from 2 to 4 weeks. But the minimally invasive surgery and the bunion realignment surgeries, you are allowed to walk right after surgery.
Great. And are they wearing a
The
boot?
immobilization for that depends on what procedure. There's a lot of different procedures for bunion realignment surgery. For a minimally invasive surgery, you may get back into a normal sneaker or shoe in 4 weeks, maybe. But for me, the general kind of post-op treatment for that, if you're walking, is a post-op shoe or a boot, a removable boot, for about 6 weeks.
Great. Is it possible to treat myofascial pain similar to arthritis?
Myofascial pain, the myofascia is sort of the covering of the muscles and tendons, and in our bodies there's different compartments. So in all parts of our body, where groups of muscles are kind of sectioned off from others, and that is the fascial planes, or the fascia around that. That's a soft tissue structure. If myofascial pain can be pain generated from that soft tissue. There's also, something called fibromyalgia, where you can have kind of pressure points in certain areas of the body. But myofascial pain, other than like taking an anti-inflammatory, Tylenol, physical therapy, and stretching, some treatments overlap. But certainly with the soft tissue problem versus a joint problem, joints, you're able to undergo an injection, and that's one of the good treatment options non-operatively for that. But for myofascial pain, especially if it's broad or kind of diffuse, mostly that is done with physical therapy and medications.
Great. When stretching, lifting my leg high and straight out, I get a sharp, almost electric pins and needles pain in the back of my heel. I had it several years ago and I was able to resolve with stretching. Any ideas on what this could be?
Usually heel pain is a few things. Could be Achilles pain, where it inserts onto the back of your heel. Could be plantar fasciitis. And it could also be maybe some nerve pain. There's a very big nerve on the inside aspect of the ankle that then transitions into the bottom of the foot, very closely associated with the plantar fascia. Usually pain like that, when you're stretching it or in certain positions, usually means that something is tight or contracted. And we would try to kind of hone in on that area with a physical exam, see what's really bothering you, where your pain is. Does it radiate into the bottom of the foot, which would kind of think that it might be nerve pain. So depending on the physical exam and sort of the characteristics of the pain, usually we would address that with a lot of stretching and physical therapy.
And then just kind of piggybacking on that, can you talk about bursitis of the heel and the Achilles tendon and how to prevent flare-ups?
Sure. If bursitis, when we're talking about Achilles, is most likely retrocalcaneal bursitis, which is a fancy word for a bursa between the Achilles and the bone. There's also a little bursa between the Achilles tendon and the skin too. But these structures can get inflamed from increased pressure or some inflammation of those structures or of the Achilles tendon itself, contractures of the Achilles tendon. And again, the Achilles problems are usually treated initially with an aggressive stretching program, depending on your pain. If you have a lot of pain and you are having difficulty even just walking around normally without pain, sometimes we do have to immobilize you in a removable cam boot And that just kind of lets the fire go out. And then we can start aggressively stretching you. Sometimes with Achilles problems, I'll see patients that were never rested, never let the kind of, everything calm down, kind of get ahead of the pain, and then we aggressively start some physical therapy. So if you have a lot of pain, we may recommend immobilization. If you don't have a lot of pain that's constant with normal walking, we'll go ahead and start that physical therapy. If you've had Achilles problems, but if you were fortunate enough to overcome them with non-operative treatment, definitely to keep that at bay is to stretch your Achilles pretty much on a daily basis. I would recommend as soon as you have Achilles problems, definitely before and after physical activity, but it would not hurt stretching your Achilles every single day to keep them as loose as possible. Because usually, again, it's that tightness in the Achilles or a contracture that will cause some problems.
Okay, I'm going to stretch mine right now while we're still talking.
Yeah.
Last question. What would you suggest for stress fractures of the forefoot?
Okay, stress fractures of the forefoot. So the most common thing is a metatarsal stress fracture. You can get stress fractures in the toes, but that's very rare. But if it's a metatarsal stress fracture, that's a really, really good question. And there's a couple factors. If it is your first stress fracture, then usually a period of immobilization in a boot, depending on, again, on your pain, you're allowed to walk in that cam boot. Usually that offloads the bone enough. But if you're still having pain, even walking with the boot, we can do a period of non-weight bearing. If you start to get multiple stress fractures, definitely in the same area too, we want to, number one, make sure that you don't have any contractures of the foot and ankle. If it's in a certain position, if you have a high arch, if you have high arches are notorious for causing fifth metatarsal fractures, tight Achilles, structures may cause second metatarsal stress fractures. So definitely important to get an x-ray, get a physical examination. And when we rule all those things out, like contractures or deformities of the foot and ankle, the treatment for a metatarsal stress fracture is usually very successful. A little bit of time, a little bit of just, taking pressure off of the bone with a boot, a little bit of reduced activity level, usually pretty successful. If we start to see patients with stress fractures, multiple stress fractures, same area, sometimes we would suggest maybe a metabolic bone workup. Is there a problem with calcification of your bones or something, vitamin D level or something like that? Calcium retention problems, something metabolic that we can look into with multiple recurrent stress fractures.
Wonderful. Well, listen, you answered so many questions. Thank you so much.
Yeah, sure.
And thank you for everybody who joined us this evening. This was recorded and you'll get it, I think, next Tuesday in your email. If you would like to schedule an appointment with Dr. Kirwan, he sees patients in our Egg Harbor Township and our Manahawkin offices. You all should have my email and my telephone number. Just shoot me an email and we can have our schedulers reach out to you. But other than that, have a wonderful night. Thank you so much. I feel like I learned so much. I really appreciate it.
Thank you, everybody.
All righty. Have a great night.